A ventilated asthmatic suddenly loses their blood pressure. Chest compressions and pressors fail, until someone disconnects the tube, a long whoosh of air escapes, and the pressure comes right back. This is auto-PEEP, the silent killer of the obstructed patient. Exhalation is passive, emptying against airway resistance with a time constant of resistance times compliance. In severe obstruction, bronchospasm and mucus, resistance climbs, the time constant lengthens, and the lung empties too slowly. Watch the expiratory flow waveform. Instead of falling all the way back to zero, it stalls above the baseline when the next mandatory breath arrives. Flow that does not return to zero is the classic bedside clue to air trapping. So the residual gas from breath 1 is added to breath 2. Breath after breath, end expiratory lung volume climbs. This is breath stacking, or dynamic hyperinflation. The recoil pressure of that trapped volume is the auto-PEEP. The alveolus overdistends. Auto-PEEP is now well above 5 centimeters of water, the threshold for clinical significance. Yet the ventilator's routine PEEP readout still shows nothing. That is why it is called occult, or intrinsic PEEP. Here is why it kills. This rising intrathoracic pressure squeezes the great veins, so venous return and preload collapse. Cardiac output plummets, and you get sudden hypotension, classically a pulseless electrical activity arrest. To confirm it, perform an end expiratory hold on a passive patient. Occlude the expiratory port for 2 seconds, flow ceases, pressures equilibrate, and the display finally reveals total PEEP. Auto-PEEP equals total PEEP minus the set PEEP. The fix is time. Give the lungs time to empty. In the crashing patient, disconnect the circuit and let full exhalation occur. The trapped gas whooshes out, intrathoracic pressure falls, venous return is restored, and blood pressure rebounds within seconds. Then lower the minute ventilation, smaller tidal volume, slower rate, a longer expiratory time, and accept permissive hypercapnia, tolerating a pH near 7.2 rather than driving lethal hyperinflation. Bronchodilators shorten the time constant. The do not miss pitfall. A low measured auto-PEEP does not exclude danger. When airways close dynamically, the most overdistended units never equilibrate with the circuit, so the hold underestimates the trapping. If the number looks normal but the patient keeps trending toward arrest, disconnect and watch what happens.